All right. Good afternoon, everybody. My name is Elliott Salamon. I am a stroke neurologist with Northwell. Just to point out, Northwell is actually one of the only regional comprehensive stroke centers. So the care that you receive at a Northwell facility, in particular North Shore University Hospital, is unparalleled in the region. Especially in Nassau County and Long Island, we are the only comprehensive stroke center. So it's really something important to keep in mind. We're going to go through what stroke is, how to prevent stroke, a little bit about the pathophysiology, meaning the medicine behind what a stroke is, and if there are any questions, you can write them down, but you can jump in. It's a small group, so it's all good. It's all good. So just very quickly, a stroke is the acute onset, meaning the sudden onset of a neurologic deficit. So this is something that's really important because there are a lot of things that happen slowly. And usually those things are not stroke. Stroke is usually something that comes on very, very abruptly. And it usually corresponds to the part of the brain that's involved. So if the part of the brain that controls strength on the right side is affected, then there's weakness on the right side. If the part of the brain that controls vision is what's affected, then there's a vision problem on the right side. And these are things that usually come on very, very rapidly. So this is somebody that's going about their normal routine. They're in a grocery store, they're in shul, wherever they are, and all of a sudden, they go weak on one side. Maybe they fall to the ground, or they say, I can't see, or they start to develop slurred speech. These are the signs of stroke, and this is something that needs to be taken extremely seriously. This is something that is 911. It's not, let me take a break and take a nap and wake up and see if it's still there. It means you have to get to a hospital right away, okay? And just given the crowd, it is a pekuach nefesh issue, right? So this is something that you're going to call 911, even if it's during Ne'ilah, you're going to call 911, okay? So just a little bit about the statistics of stroke. So stroke is extremely common. It's the 5th leading cause of death, and that's actually improved because of some of the work that has been done recently in stroke. It has bumped down the list. So it's no longer number 3 like it used to be when I was a resident, and it's no longer number 4 like it was when I was a fellow. It's now become the 5th leading cause of death. And what's important also is that it isn't so much the stroke itself that causes the death, but it's the complications of the stroke that cause the death. So somebody that, let's say, is immobile, they have weakness on one side of their body because of a stroke that affected that part of the brain, has difficulty walking, and because of that, it predisposes them to develop pneumonia, it predisposes them to develop blood clots in the leg that could be fatal, and other medical complications as a result of the stroke. Many of the strokes that we see are recurrent strokes, right? So these are oftentimes the second stroke that the patient is having. And why is that important? Well, it's very important because the first thing that we need to do when someone has a stroke is figure out why they had it so we can prevent another stroke from happening, right? So very commonly patients will come into my office and they've had a stroke, and thank God they're doing very well. They have no deficits, they're perfect, okay? And I always tell my patients, I say, this stroke is not the problem. The stroke that you've had is not the issue. It's preventing the next stroke that's the problem. And that's why it's very important to seek care for any sort of neurologic event. Any sort of stroke-like symptom needs to be investigated, even if the patient is doing fine. Because just because the patient is back to normal doesn't mean they're going to continue to be that way, and doesn't mean that we can prevent the next stroke appropriately. We have to do the right testing to figure out why the stroke happened. Many strokes happen in older people, but there are also a whole bunch of strokes that happen in young people. And I have a small sort of population in my practice of patients that are really under 25, under 30 who have had strokes. And in these patients, you really need to do that exhaustive search to figure out why the stroke happened, because you really don't want to miss the ability to prevent another stroke. Okay, so it makes it all the more important. And of course, as you can imagine, stroke is one of the leading causes of disability. And it's estimated that the numbers in terms of stroke disability are in the tens of billions of dollars projected, because the unfortunate thing with stroke is that it causes disability rather than death. So many illnesses, like heart attack, let's say, causes death. This causes long-term disability. And in fact, much of this expo here is dedicated to the care of patients with stroke and with other traumatic brain injuries and other injuries that require long-term care. So again, strokes can be divided into different types of strokes, right? So usually when we think of a stroke, we think of a clot coming from somewhere, coming from the heart, coming from the carotid artery, which is one of the big arteries that goes to the brain, sometimes coming from within the brain itself. And that clot causing a blockage in an artery. And when that artery is blocked, every part of the brain that gets blood from that artery isn't getting blood anymore, and that is a stroke. There is also a different kind of stroke called a hemorrhagic stroke, and that's where instead of a clot forming in the heart or in the carotid artery or within the brain, there's bleeding that happens spontaneously in the brain. So for whatever reason, an artery bursts, and when it does, there's bleeding inside the head. And that kind of stroke initially is much more severe and is much more neurologically devastating than an ischemic stroke. Then ischemic meaning lack of blood supply to the brain in this case. Okay? Most strokes, though, are caused by a clot rather than bleeding spontaneously in the brain. Hemorrhagic stroke we spoke about. Okay, so this is very important, right? This is what it's all about. These are the signs of stroke. Okay, because I can't tell you how many times I walk into the room and the patient had signs of stroke, and people either said, you're going to be okay, it's nothing, it's no big deal, you know, take a nap, wake up, you'll feel better. That's exactly the wrong thing to do. Okay, so these are the signs of stroke. So it's numbness on one side of the body, right? It's sudden confusion, difficulty speaking, not understanding what people are saying to you, trouble getting the words out, not being able to express yourself well, trouble seeing either in one eye or in both eyes, trouble walking, imbalance, and a severe headache, right? They say it's the worst headache of your life, right? So even patients that have migraine headaches, this headache is the worst headache of your life. And that is an emergency. Okay? And the reason why it's so important to recognize the signs of stroke is because there are certain treatments that are very time sensitive. If somebody makes it to the hospital within a certain window, and that window is usually within 4.5 hours or 6 hours or 24, whatever it is, there are certain treatments that we can provide that we cannot provide outside of that time frame. So it's very important to get to the hospital in time. And this is something that cannot be emphasized enough. There is a medicine, I'm sure you're all familiar, a clot-busting medicine called TPA. TPA is a medication that will break up a clot that forms. And it can only do that, and is only safe to take this medicine if we get the medicine in time. If there's a delay in getting this medicine, it becomes too dangerous to take this medicine, and we can't do the treatment for stroke. That's why it's so important. Some of the other things that we can do is called endovascular therapy. So this is where you go up through the groin under anesthesia, you go into the brain, and you actually mechanically pull the clot out. Okay? So that's another treatment that we can do. In particular, North Shore University Hospital is one of the only hospitals on Long Island that does that. So God forbid if something were to happen in our community, in the 5 towns, that would be the hospital to go to. So TPA, so the way the model is that you not you, God forbid, but a person will go to the closest hospital that they can go to. At that hospital, they will get TPA, because TPA is something that basically any hospital can administer. Then what happens is that a phone call is made to the stroke neurologist, let's say if I'm on call, and what we do is we transfer the patient from whatever hospital they're at to North Shore University Hospital, where there's a stroke team waiting there for that patient to take that patient up and to do a procedure if it's needed. Okay, so it's called the hub and spoke model, right? So there are like these little hospitals, and they all transfer to the bigger hospital. Okay, so for instance, in the I live in Cedarhurst. I'm sure many of you live nearby. If someone, God forbid, has a stroke, they're taken either to St. John's or they're taken to South Nassau, and from there they would be transferred for endovascular therapy to North Shore University Hospital, which is the only hospital that's really doing this procedure. Okay. And again, just to emphasize 911, right? It's pikuach nefesh. It's an emergency, right? So again, the wrong thing to do is to go back to sleep, right? The right thing to do is 911 to the hospital. The wrong thing to do is to make an appointment with your primary doctor, right? The wrong thing to do is to call your internist and say, oh, I'm having slurred speech, right? It's just 911 or Hatzalah, whatever it is, right? Okay, so again, this is just a mnemonic that's kind of easy to remember. It's the be fast mnemonic, right? So being fast means it's all about time, right? Because you got to get to the hospital in time. Balance, so the acute onset, meaning the sudden onset of incoordination, visual problems, facial droop. Sometimes the first thing that you notice is that there's a droop of the face. Arm weakness, speech, slurred speech, or not being able to find the right words to say. And then the T is for time. The T represents the fact that you need to get to the hospital right away. So again, just the importance of 911, the importance of calling Hatzalah, getting the ambulance there. And then we discussed a little bit the time-sensitive nature of stroke. So again, it's something that needs to be done ideally within 3 hours. If not within 3 hours, it could be done within 4.5 hours. But the point here is that the sooner you do it, the better the result, the less complications, and the more likely the patient is to return back to normal. Okay? And then we get to the risk factors for stroke, right? Now, a lot of this is common sense stuff. A lot of these are the risk factors for heart disease, and they're the risk factors for all sorts of vascular disease. And they're relatively straightforward, right? So obviously, age is the biggest risk factor, and unfortunately, it's a risk factor that's not modifiable, right? Meaning there's nothing you can do about it. We're all getting older, okay? Family history is very important, right? Especially, by us, we all know what a Shabbos Kiddush looks like and the kind of food that's served, right? All of this is very important and very frequently runs in families. Very frequently, heart disease runs in families. Heart disease runs in my family, right? So this is very, very common, especially in our community. And then the medical history, right? So if someone has had a heart attack, someone has stents in their heart, if someone has previously had a stroke, if someone has an abnormal cardiac rhythm, something called atrial fibrillation, this is screaming the possibility of stroke. okay? That's why it's very important to go for routine health screenings, to at least get an EKG once a year to make sure that you don't have an abnormal electrical rhythm, you don't have atrial fibrillation. And of course, smoking is just, I mean, the worst thing in the world, right? I mean, it's funny. I know that you know, within certain populations in our community, smoking is more acceptable, but I for the life of me can't understand why. I mean, it's the complications of smoking that you see both in heart disease, in stroke, in kidney disease, and lung cancer, and COPD, and I mean, it's just horrific, absolutely horrific.
What about daily sodium intake? What do you recommend?
So daily sodium intake is part of diet, and diet is very important. And what's recommended is a Mediterranean diet, right? So a diet that's very high in protein, very high in fish, and very low in carbohydrate.
With sodium?
So sodium, a low sodium diet.
Do you have a number? How many sodium milligrams?
How many milligrams of sodium? Off the top of my head, I couldn't tell you. But certainly the less sodium intake that you have, the better it is, not so much for its direct relationship to stroke, but because of its indirect relationship to stroke. Because the less sodium you have, the less likely you are to have high blood pressure. And the less likely you are to have high blood pressure, the less likely you are to have a stroke. So that's the relationship there. Which brings me to blood pressure, which is also one of the single best things that you can do to decrease your risk of stroke, is to do everything that you can to maintain a normal blood pressure. So this is something that, again, we're all a little bit, you know, it's one of those things that's taken for granted, and it's one of those things that, that everybody sort of jokes about a little bit until it's not a joke, okay? You know, people always say, oh, I have high blood pressure and this and that, but it is called the silent killer, and there's a reason for that, because it's funny until the day that it's not funny. So that's probably one of the single best things that you can do also to decrease your chance of stroke, is to have your blood pressure checked and have your blood pressure maintained under 120/80. Okay, even if that means with medication. Physical inactivity, right? So we all know this also, that the best thing that you can do is to do some form of physical activity for at least 30 minutes a day. It doesn't mean you have to join a gym, and it doesn't mean you have to get on a treadmill. It means things like, you know, park a little bit further in the parking lot and walk for 10 minutes. It means take the stairs instead of the elevator. It means sort of common sense things that can get your heart moving a little bit more than otherwise. Nowadays, we all park 10 feet from our office. We take an elevator up to our desk, we sit down at our desk, and we order lunch, right? I mean, it's very sedentary. Just doing a little bit more than that can be extremely beneficial. And then body weight, right? So obviously there's a correlation between obesity, between body habitus and weight, and stroke. And unfortunately, the more heavy you are, it increases your risk of stroke as well. And diabetes. So diabetes is something that, again, is very much like blood pressure, in that it's often kind of a joke until it's not a joke, right? Listen, I have family members like you have family members, and they say, oh, I shouldn't have this because I have diabetes, but I'm going to take this piece of cake and blah, blah, blah. But it's serious business. And diabetes and high blood pressure absolutely cause stroke, and they cause...
How do they cause stroke?
So what happens is that...
What's the science behind it?
Yeah, so there are two etiologies, okay? So one is that high blood pressure itself causes damage to the inside of the artery. So the fact that the blood is moving with such force causes physical damage to the inside of the artery, the same way if you were to take a knife and cut the inside of that artery. Then there's a healing process that kicks in. That healing process, just like if you cut your skin and get a paper cut, you get that scab. So you get that scab in the brain. On the inside of the artery. And that occludes the artery. Okay? So that's one mechanism.
Diabetes?
Diabetes works a little bit different. What happens with diabetes is when your body is unable to use glucose, you start to break down fat, which means that you have more circulating fat in your body. those fat deposits can get lodged in the arteries of the brain. They can also get lodged in the arteries of your eye and of your kidney and of your nerves. That's why people with diabetes get neuropathy. They get renal failure. They get vision problems. They get stroke. They get heart attack. It all has to do with an increased amount of fat that's circulating in their body. Because remember, if the body can't use glucose, if the body can't use sugar because it's not taking it into the cell, it's circulating in the blood, then the body has to utilize other forms of energy. If it's not glucose, it's going to be fat. So you start to break down fat. That's why when people are initially diagnosed with diabetes, they lose weight, because they're breaking down fat and using the fat as an energy source. Right? Does this make sense? I mean, this is very common. The patient that comes to me and says, you know, I've been urinating a lot, and I lost like 20 pounds lately, and I don't know why. I know why. You have diabetes, right? So this is very common stuff, and it absolutely causes stroke. And the strokes that it tends to cause...
Type 2 also, or just type 1?
No. Type 2 and type 1.
Oh, I see.
Yeah. Both types of diabetes. So type 1 diabetes is more of a congenital type of diabetes, meaning you're born with it or it develops at a younger age. Type 2 tends to be a different type of diabetes that comes because of weight gain and obesity and lack of movement, and it's more of an insulin resistance type of diabetes.
How can a stroke in the eye be prevented?
Right.
Or are there any signs, warning signs?
Of a stroke to the eye.
Right.
So, aside from all of the routine prevention stuff, meaning making sure your LDL is okay, making sure your blood pressure is okay, making sure you're not smoking, making sure you don't have atrial fibrillation, making sure you don't have any carotid stenosis, right? You get the ultrasound of the carotid artery. A lot of internal medicine doctors do that. If you do have vascular risk factors, being on an aspirin or Plavix or one of those type of medicines can decrease the risk. But when I see patients who have a stroke of the eye, it's called amaurosis fugax, right? It has a particular name. A curtain comes down and there's visual loss. Sometimes the ophthalmologist, the eye doctor, can see the clot in the eye, okay? When I see patients with that problem, I give them the same speech that I just gave before, which is that I'm not worried about this event, okay? I'm worried about figuring out why that stroke happened to prevent a much worse stroke from happening. Obviously, losing vision is bad, but being hemiplegic, being paralyzed on one side of the body, is much worse. So in many ways, that is the first sign that there's something wrong, and it screams that a workup has to happen. So it drives me crazy when people that I bump into in shul will tell me, oh, you know, my vision went blank for 2 minutes, but it came back, so I'm fine. Like, no, like that's a problem, right? That's a very serious problem.
What do you do about it?
So we work them up. We check if they have atrial fibrillation, right? We put sometimes a loop recorder in. We put in a device to monitor their heart. It can stay in for up to a year to see if they have an irregular heartbeat. We get them an echocardiogram to see what the function of the heart is. If the heart is not beating properly, a clot can form in the heart, and that can go straight up to the eye. We see what their carotid arteries look like. Is there a blockage in the carotid artery? If there is, then they might need a surgical procedure to open that up. We see what the blood vessels in the brain look like. There might be certain medicines or other procedures to open up those arteries. So it's important to not neglect it, right? The point is that while there are some strokes that just happen, and you know there isn't a lot you can do about it other than prevention, many times there are signs that happen first, and it's ignoring those signs that is devastating, because that's what allows the other stroke to happen. Does that make sense?
How do you avoid AFib?
So AFib is something that is very difficult to avoid. It comes along with age. There's an association with alcohol. There's an association with sleep apnea. There's an association with weight. Preventing the AFib is not so much the problem as making sure you don't have it or do have it, and being treated appropriately, right? Because as you get older, your likelihood of developing atrial fibrillation increases.
How do you make sure you don't have this?
So it's routine maintenance, right? It's going to a doctor and getting an EKG. You can't tell. You can't tell by whether or not you have palpitations if you have atrial fibrillation. That's very mythological. You can feel nothing and still have AFib. And the treatment now is not like the old days. I know we all think Coumadin and checking the INR. Right now you see advertised all over. There's Eliquis, there's Xarelto, there's a bunch of medicines that are just popping a pill. It's not a big deal. It's not a big deal, but it's knowing about it, right? Knowing is half the battle, as they say, right? So just being aware of it is so important.
So sleep apnea you just mentioned.
Yep.
How do you go about it to rule it out?
Right, so sleep apnea is something that is very, very common. And it's one of those things that my wife will wake me up in the middle of the night and say you're snoring, and that's something that's worth investigating. People that have very big necks are at risk for sleep apnea. People that wake up tired are at risk for sleep apnea. People that find themselves gasping for air in the middle of the night have sleep apnea. Now, sleep apnea is not it's not a joke. It's not, oh, my husband snores. It's a real problem. It predisposes to heart attack. It predisposes to stroke. It's something that does need to be taken care of.
What should we do about it?
So the treatment for sleep apnea is, of course, the weight loss and that, but there are certain devices that you sleep with that go in your nostrils and basically push air into your lungs that are treatment for sleep apnea.
Is it over-the-counter kind of thing?
So it's not over the counter. You really have to be seen by a pulmonary doctor or a sleep specialist. And if you want, I'm happy to put you in touch with one. But that's really very important in terms of preventing stroke, because it is one of those things that we don't really even think about, but it is definitely a risk factor.
There must be a difference, like snoring regularly, or these people who stop at one point and all of a
So right, so
most people snore like at a regular.
right. So what happens is that the only way to really sort that out is to do a sleep study, is to be monitored while you're sleeping, and it's done at home. It's not like the old days where you have to sleep in some office or wherever. And by monitoring the sleep pattern, you're able to determine whether or not there's real sleep apnea. And sleep apnea is very common. I mean, this is very, very common stuff. And it's something that, especially coupled to, because it usually goes along with other things, right? So someone who has sleep apnea usually has a little bit of high blood pressure, and usually is a little bit overweight, and usually has a high cholesterol, and maybe has a little touch of diabetes, and maybe has some stents in their heart, right? So it's part of this whole overall picture that exists, right? And again, it's something that you can do something about. You can't do anything about age, right? You can't do anything about some of the other things, or some of the other things are harder to deal with. But sleep apnea is something that you could do something about. Sorry.
If you already had clot, you take blood thinners, are you more at risk for a stroke?
So if you've had an ischemic stroke, depending on...
I'm talking about myself. I had a clot in my leg, and I take blood thinners.
Right, so that's a DVT, it's called. That's a clot in the veins of the leg. And the concern is that clot can go from the leg to the lung, and that's something that could be life-threatening. So the treatment for that is very similar to the treatment for any clot that develops anywhere in the body, including atrial fibrillation, a clot developing in the heart. And the treatment for that is a blood thinner, right? So that blood thinner decreases your risk of an ischemic stroke, but increases your risk for a hemorrhagic stroke, right? So you find that in medicine there's no wizardry to the whole thing, right? Everything is risk and benefit. Everything is a balance between the side effects of the medication and the benefit of the medication, right? So obviously someone who has a clot in their leg needs to be on certain medicines. But there's a side effect and there's the potential for harm, which is, God forbid, if someone on a blood thinner trips and falls down a flight of stairs, there's a major problem. There's a major problem.
Catch-22 that the doctor puts you
100%. And all of medicine is like this, right?
in bed.
All of medicine. There, you start to realize in medicine there are very few cures, right? Unless somebody has a sore throat or an appendicitis, there are very few cures in medicine. It's all about weighing risks and benefits and being on medications to prevent complications of disease, right? It's not all cut and dry. With the exception of infection and certain surgeries, there's no cure for diabetes, right? You have to do a lot of things to prevent complications from diabetes.
You ready for these cards?
I guess so. Yeah, sure. Yeah.
Any relationship insufficient sleep and stroke?
So, to my knowledge, I don't know of a relationship between insufficient. I know that it's been written about the people that work nights and are sort of have like weird circadian rhythms, are at increased risk for certain things. But I think that would be a far-fetched etiology for stroke, right? I think that there are things that are much more common that need to be prevented. Sure. Okay. All right. What could be done before the patient gets to the ER? So that's a very good question. So the answer is, and I get this all the time, should I give them aspirin, right? So usually we don't recommend giving aspirin to somebody who has a stroke because until they get to the hospital and get a CAT scan of their head, I don't know if that stroke is bleeding in the head or if that stroke is an ischemic stroke. So yes, you're right, for an ischemic stroke, treatment would be aspirin. After they get TPA, 24 hours later they would get aspirin. But until you know what's going on, giving somebody a bunch of aspirin is not the right thing to do. So the first thing to do would be to keep them safe and to keep them, if they're in a dangerous position or in a dangerous place, they should be taken out of that dangerous place. Right, so I mean, if somebody falls down in a parking lot, you want to make sure they're not at risk for getting run over, that kind of thing. How long should you give a headache to go away before taking Excedrin? So this is something that really depends on the person. So there are certain people that are headache people, right? There are certain people who get headaches since they are 12 years old, and they know their headaches, and they say, oh, this is my headache, and sometimes they get visual changes, sometimes they get numbness, and there are people that just know this about themselves. And then there are other people in the world who never get a headache and don't even understand what a headache is. I've had patients come in and say, is this what a headache is? Am I having a headache? I'm like, well, if you have to ask, then you don't know. So it really depends, right? If someone has a headache that is the same as their usual headache, then that doesn't require going to the hospital, right? But if somebody has a headache that is the worst headache they've ever had in their life, and I can tell you, speaking to enough patients, these are the patients that are on the floor in the fetal position, holding their head, rocking back and forth in pain. That is a problem, okay? Especially if it's accompanied by weakness or numbness on one side or on the other side. And how does the ER differentiate between ischemic and hemorrhagic? So the only way to differentiate is with a CAT scan of the head. And this is something that's been looked at. It's been studied, where they asked a bunch of stroke neurologists, is this patient having a hemorrhage?
The first hospital you brought to?
The first hospital that you go to, before you give TPA, before you give a clot-busting medicine, you need to know if there's bleeding in the head. The last thing you want to do is give a blood thinner to someone who's bleeding, right? I mean, that would be, lethal. So the only way to determine if they're having an ischemic stroke or a hemorrhagic stroke is with a CAT scan. This is why it's so important to get to the hospital, because in a living room, there's no way to know what's going on. There's no way to know. What's done for someone who's on blood thinner who's diagnosed with a hemorrhagic stroke? Okay, so it's a complicated question. So if someone is on a blood thinner, it very much depends on which blood thinner they're on. Some of the agents are reversible, meaning there are certain medicines that we can give. If someone is on warfarin, they're on Coumadin, then there are medicines that we can give to reverse the effects.
But you have to know which ones.
Absolutely.
You should keep a little card on.
100%. And it's so important that family knows what medicines everybody's on, because the only way for me to know when I walk into the room is based on what people are telling you. And with stroke, I have to tell you, we make life and death decisions with very limited information. And we do this at 3 o'clock in the morning, right? I mean, stroke doesn't always happen at 2 o'clock in the afternoon. We get woken up at 3 o'clock in the morning, and we're making life and death decisions based on very, very limited information. Information that we're getting sometimes from EMS, that we're getting from friends, we're getting from families, we're getting from caretakers. We're just trying to piece it all together because it's so time sensitive.
But if the person is unable to speak, it's a problem.
Absolutely. Absolutely.
And it's a good idea to have one of those bracelets listed.
I think it's a very good idea. Or certainly if someone is in a position where they're on a blood thinner, then somebody should know, someone else should know that they're on a blood thinner.
If you have an adult who has a stroke and is rushed to the hospital, then they're not accompanied by either a family member or anyone who would know the medication. What could they do in advance so that they would have a list of their medications with them?
So again, it's all about making sure that someone knows, either with a wristband, you can have a wristband that says on a blood thinner, or just someone in the family has to be aware that this person is on these medications.
So in other words, a telephone call will be made ASAP to a family member.
Absolutely. Yeah, I mean, we're going to try as best we can. Listen, I mean, sometimes we find people down in the street and we have no idea who they are, they have no wallet, and we can't track them down, and there's nothing you can do, right? But if it's somebody, usually we're able to figure out what's going on because somebody called us, EMS came to the house, EMS looked through the medicine cabinet to try to get as many medicines as they can. So a blood test can, but it doesn't give us the details, right? And plus, I would rather not wait for the labs to come back if I don't have to, right? Because again, I mean, not that takes forever. It takes another 15 minutes, but you're talking about something that's so time sensitive that 15 minutes, I can tell you 15 minutes is a lifetime when you're sitting there with the TPA in your hand and you're waiting for a lab to come back. 15 minutes is forever. Because you know that every second that you wait is more and more damage to the brain. How do you get rid of a hole drilled in the brain? Right. So the clots that we're talking about with stroke are clots that are in the arteries of the brain. And you go in just like you do a cardiac catheterization, only instead of going to the heart, you go up to the brain. And inside the brain, you put in a device to suck the clot out, to pull the clot out. Okay? This is different. I think what you're talking about with drilling a hole in the brain, that's for something called a subdural hematoma. So that's bleeding that's not in the brain, but it's bleeding outside of the brain, pushing against the brain. So that's also a problem, obviously. But it's a problem that's a little bit different than the stroke that we've been speaking about. Because this is bleeding outside of the brain, pushing against the brain. And if this is severe enough, the only treatment for that is to drill a hole and to take out that blood. Okay, and again, that's something that is not done at our local community hospitals. It's something that requires a little bit of a higher level of care. So if they see on a CAT scan, again, it's all about the CAT scan, right? You got to get that CAT scan. You got to get to the hospital to get that CAT scan. If you do that CAT scan and you see that there's a subdural hematoma or an epidural hematoma, which is a different type of bleeding on the brain, the treatment for that is surgical. The treatment for that is to surgically remove that blood.
What you call the one through the groin?
So it's called an endovascular therapy for stroke, right? So it's very similar. If someone's having a heart attack, you go in and you do that same thing to try to open up the coronary artery. Here, instead of treating the coronary artery, you're treating the artery in the brain.
Sometimes I'm pulling off a muscle left of my mouth, very sporadically.
Yeah.
Is it something to check out?
So usually that's something that's caused by a local muscle problem, right? It comes along with anxiety and nervousness and having too much coffee. Too much coffee.
That's a reason.
It tends to cause, like, you get like the twitching in your eye. Also, people very commonly get twitching in their eye, and it's usually nothing serious. If you're nervous about it, you can get it checked out.
I try to have enough coffee again.
All right, so there you go. Problem solved. Problem solved.
For hemorrhagic stroke, the brain is going out.
It depends on where the location. Depends on the location of the hemorrhage. If it's a hemorrhage that's very deep inside the brain, then you can't get it out. If it's a hemorrhage that's more superficial towards the surface of the brain, then sometimes you can take it out.
And in the brain itself, deep in the brain, what do you do for that?
If it's deep in the brain, you don't do anything. It can't be treated because you can't get that blood out without causing a significant amount of damage.
So what do you do?
So what's done is controlling the blood pressure aggressively, reversing any possible blood thinner, even aspirin or Plavix or one of those medicines. You give platelets to try to reverse it, and you try to decrease that bleeding from happening, mainly by controlling the blood pressure is usually the most important thing. The patients that have bleeding in the deep part of their brain, it's almost always because of high blood pressure. Okay, so the single best thing that you can do is control the blood pressure in those patients. And those are the patients that come in and their systolic blood pressure is like 230, and they're started on all sorts of IV medicines to prevent the bleeding from getting worse. Yeah.
Do we get your business card?
I'll give it out.